Welcome to week 13. In this lecture, we're going to cover part 2 of the lecture that we started last week. We're going to look at the history of mental health treatment. You will learn about 3 major topics: the medical approaches of the early to mid 1900s, the relationship between clinical psychology and World War II, and 2 other treatment options that emerged in the middle of the 1900s: behavior therapy and person-centered therapy, which was part of humanistic psychology. Last week, we learned about some of the earliest approaches to the treatment of mental illness. Then we looked at the reformers of the Enlightenment period, and then we looked at psychoanalysis. We looked at Sigmund Freud, Anna Freud, Alfred Adler, and Carl Jung. This week, I want to turn our attention to the medical approaches. In the 1920s and 1930s, there were several medical approaches that were invented. Most of these medical approaches were used by doctors and psychiatrists. In this section, we will talk about fever therapy, insulin therapy, Metrozol shock therapy, electroshock therapy, as well as the infamous lobotomy. At the very end of this section, I explain modern day lobotomies. They're no longer called lobotomies, but we still purposely, intentionally damage brain tissue in order to minimize the expression of symptoms. Most of these approaches focused on severe mental illness, things like schizophrenia. Today, we have adjusted some of these medical approaches to be used with patients who have obsessive compulsive disorder, major depression, severe anxiety, and less severe forms of mental illness. It's important to realize that the early medical approaches were only tested on a small number of individuals. While some patients enjoyed symptom improvement, the medical approaches did not always work. They did not provide enough benefits to outweigh the risks. Lobotomies, for instance, intentionally damage brain tissue and would sometimes change people's personalities, not just minimize their symptoms, but also change other behaviors that were not targeted by the strategy. An Austrian psychiatrist, Julius Wagner-Jauregg, created fever therapy in 1917. He published a report about how he had intentionally injected his patients with malaria. His patients had psoriasis, which is a debilitating condition that results from neurosyphilis, an infection of the brain. Once his patients were injected with malaria, they suffered from an intense fever for several days. Once the fever passed, 50% of his 8 patients seemed to have fewer symptoms related to the psoriasis. He concluded that the fever in and of itself was what caused the reduction in symptoms. Fever therapy was popular in the 1920s and early 1930s until penicillin was discovered as a cure for both neurosyphilis and psoriasis. Here is an example of how fever therapy was used to treat patients with mental illness. Also in the 1930s, a Viennese physician, Manfred Sockel, created insulin shock therapy. He injected his patients with enough insulin to lower their blood sugar and induce a coma for about 20 minutes. Then he would inject them with enough glucose to bring them out of the coma. This was repeated 20 times at least over a period of many days, many weeks. Eventually, after doing this about 20 times, his patients reported some symptom relief. Unfortunately for the patients, this relief was only temporary. Despite this not being a long-term solution, it spread quickly to the United States. In the late 1930s, more than half of mental illness institutions used insulin shock therapy. In this short video clip, you will see a patient undergoing insulin shock therapy. If you don't want to watch, you don't have to skip to the next slide. But if you do want to watch, you will notice that his mouth is open most of the time and he's drooling. This was one of the side effects of insulin therapy, lots of drool. They covered their eyes in order to minimize the amount of stimulation while they went through this therapy. At the same time, a Hungarian psychiatrist created yet another option, Metrozol shock therapy. It was created by Ladislas Meduna in Budapest, Hungary. He noticed that his patients who had both schizophrenia and epilepsy did not experience symptoms after a seizure. He thought he could purposely induce seizures in order to minimize symptoms. He injected his patients with Metrozol, which is a powerful seizure-inducing drug. And while many of his patients did in fact enjoy symptom relief temporarily right after the seizure, some of the patients had extremely violent seizures, so violent that they would break bones, ribs, sprain ankles and wrists in the process. Some of the patients reported it as an extremely traumatic experience and also had retrograde amnesia. Despite all of these challenges, the option spread to the United States in the 1930s at the same time that insulin shock therapy was also becoming more popular. By the end of the 1930s, 2/3 of institutions used Metrozol shock therapy. These two types of shock therapy would eventually be replaced by Electro-Convulsive shock therapy, ECT, in the 1950s. And in 1982, the FDA revoked Metrozol's approval. So Metrozol can no longer be used to purposely induce seizures for the treatment of mental illness. In this brief video clip, you will see a patient undergoing Metrozol shock therapy. If you don't want to watch, skip to the next slide. If you do, you will notice that this patient experiences severe seizures. The staff have to hold the patient down. They've actually got him tied to the bed. This is for his own safety. The seizures were a natural response to the Metrozol. The seizures are not by choice. This individual is not acting. If any one of us were injected with Metrozol, we might respond in a very similar way. All of the patients had seizures. Some were more severe than others. In 1938, a neurologist from Italy, Ugo Carletti, invented electroconvulsive shock therapy, sometimes shortened to electroshock therapy. He would apply electricity to his patient's temples, which would induce a convulsive seizure. Although the first treatment for humans was invented in 1938, Carletti had practiced on pigs, kittens, rabbits for several years before publishing his results from his human trials. Like many of the other physicians and psychiatrists at the time, he believed that it was the seizure, not the electricity per se, it was the seizure that was producing symptom improvement. As soon as it was introduced, it spread like wildfire throughout Europe and the United States. It became extremely popular in the 1940s and 1950s. It replaced the other forms of shock therapy. It was unpopular in the 1960s and 70s, but regained acceptance in the 1980s. Today, it is not as popular as it was in the 1900s, although you can still find some doctors and psychiatrists who will perform it. This is an example of a patient undergoing electroconvulsive shock therapy. At about the same time that Carletti was experimenting with electroconvulsive shock therapy, two neurophysiologists were also experimenting with yet another option. In 1935, two Americans, Carlisle Jacobson and John Fulton, published their work with chimpanzees. They had performed the first animal lobotomies. And what they did was they severed the tissue between the frontal lobe and the lower regions of the brain. So right about here, they severed brain tissue. And they did this in two different chimpanzees. You can see Dr. Fulton with one of his chimpanzees in the image here. What they found was after severing this connection between the higher brain and the lower brain, the chimpanzees were less aggressive. And the good news was their mental functions were not impaired. The damage to the brain had not changed the chimpanzees in any other way except to make them less aggressive, according to these two doctors, according to their research and according to their observations. 1 year after Jacobson and Fulton published their work, a neurologist and a neurosurgeon from Portugal published their results from the first human lobotomies. Their names were Antonio Egas Moniz and Almeida Lima. These two individuals together were responsible for the first lobotomies. So sometimes you'll hear lobotomies of this nature called the Moniz-Lima lobotomy. They used a Lacone, you can see an example on the next slide, to make intentional cuts in the brain tissues of 20 of their patients. Technically, historians refer to this first version as a prefrontal leucotomy with a C, named after the instrument that they used. The first step was to drill 2 holes, one on each side of the head, about right here. Insert the Lacone, which looks a lot like a scalpel, and then move the Lacone back and forth to sever some of the brain tissue. Moniz and Lima had figured out exactly how far the Lacone had to be inserted into the hole, and they figured out exactly at what angle to move the Lacone back and forth. They had practiced on at least 20 patients in order to figure out the procedure. 14 of their 20 patients enjoyed symptom relief. At first glance, this looks like good news, right? And many psychiatrists, doctors, and even psychologists thought that the lobotomy could be the next great treatment for mental illness. The problem was, by severing the brain tissue, Moniz and Lima changed their patients, not just in terms of their symptoms, but also their behaviors, their expression of emotions, the way they talked, the way they walked. Some of their patients would stare out the window for hours at a time. Fortunately, they recognized this limitation and urged others to only use this procedure on patients with severe mental illness. Moniz was awarded a Nobel Prize in 1949 for his work on lobotomies. In the 1940s, two American neurologists, Walter Freeman and James Watt, recreated the prefrontal lobotomy and called it lobotomy. They would lift up their patient's eyelids, insert an ice pick in the space, hammer that ice pick in with a hammer. Once the ice pick was inside the skull, they would move the ice pick back and forth to sever brain tissue. Compared to the Moniz-Lima version, this one was faster, it was cheaper, and according to many people, it was safer. The patients did not have to be put under, they could be kept awake for the procedure. There was less risk of infection, and they were able to cut more fibers using this version than they were with the prefrontal lobotomy. Throughout his life, Freeman conducted at least 3,500 transorbital lobotomies. Eventually, his partner, Watt, gets fed up with the procedure and the outcomes of the procedure and leaves Freeman. Like the prefrontal lobotomy, the transorbital lobotomy also resulted in many of the patients not acting like they did before. Their personality changed, their expression of emotion changed. And once again, many of them spent the rest of their life just sitting and staring. The photo on the left is of Dr. Freeman conducting a transorbital lobotomy on one of his patients. In the image on the right, you see an illustration of how the procedure works. By the early 1950s, more than 18,000 people had underwent a lobotomy of some form. The public was growing more and more uncomfortable with the idea of purposely damaging patients' brains, both the general public and the scientific community. In the mid to late 1950s, several antipsychotic medications were produced. One of them, Thorazine, was referred to as the chemical lobotomy. For those of you who are interested, I'm going to show you a brief clip of a lobotomy being performed in the mid-1900s. If you don't want to watch, go ahead and skip to the next slide. One of the number one questions I get about lobotomies is, are they still performed today? The answer is yes and no. Yes, we still intentionally damage some patients' brains in order to help them cope with the symptoms of chronic depression and in order to treat obsessive compulsive disorder. We use methods like you see here: cingulotomy, capsulotomy, stereotactic surgery, and gamma knife surgery. But technically, no, the modern day procedures are not like the original lobotomies. We do not use Lacones and we do not go through the eye. Let me show you some examples of modern day versions of the traditional lobotomy. Cingulotomy and capsulotomy are probably the closest cousins to lobotomy. In both instances, specific parts of the brain are damaged. With deep brain stimulation, an electrode is inserted in the brain and left there permanently. Electricity can then be used to stimulate that part of the brain. Gamma knife surgery uses radiation to destroy different parts of the brain. In the image on the left, you can see the results of an MRI after bilateral cingulotomy. you can see the 4 areas, the 4 lesions in the brain. In the image on the right, you can see what it looks like to have the electrodes implanted in the brain, sort of the location of where they are placed. Again, we don't use lobotomies today. We use other forms of medical treatments. These treatments are reserved for the most severe cases and are only used when the patient has found no other option that works for them.